Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to It's the Year of the Horse. Happy Chinese New Year. Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice, your trainers, or even your dog lead. Here's what's bubbling up as we dive in search of our pearls for the second time this month.
Navigating grief in general practice. One of the privileges of our work in general practice is being able to experience all of life's phases for the people we provide care for, and loss is an inevitable and universal part of life. Grief is a natural response to loss, and it can be one of the most challenging experiences that we face as humans. Join us as we unpick this emotive but very important topic for us all and find out why health professionals are particularly vulnerable. Meningitis and meningococcal disease, our knowledge must outweigh experience. Bacterial meningitis and meningococcal disease are conditions that strike fear into the hearts of parents and clinicians alike. Fortunately, due to vaccinations, we don't see them often. But this means that our knowledge and ability to respond quickly must outweigh our experience. Stay tuned as we look at NICE's 2024 guidance that changed recommendations around when to suspect meningitis and meningococcal disease and when to administer prehospital antibiotics. And now for the third pearl of the month, but the first of this episode, we're now going to discuss navigating grief in general practice. Working in general practice gives us insight into all aspects of life, things we may be familiar with and things that open our eyes. We're able to support patients from all walks of life in their walk of life. And as primary care clinicians, we really do practice the concept of cradle to grave in healthcare, as described in 1948 when the NHS was created. Whilst there is huge joy in many parts of our work, loss is an inevitable and universal part of life. Grief is a natural response to loss, and it can be one of the most challenging experiences that we face as humans. It can also impact us as health professionals as we encounter repeated episodes of death and dying in our work. Just as when we have discussed similar difficult topics before, if you need to duck out of this episode and come back another day, then we fully support you on that. We will be here. If this content impacts you personally, you are not alone and support is available. You may find help from bereavement support organisations helpful. There are links in the article and there are many options. There's also the Practitioners Health Programme and your own personal GP to support you. After all, we are all humans too.
Yeah, absolutely. Now, in January, the Good Grief Festival launched its 2026 season, offering training to primary care professionals. We're going to put a link in the show notes to this. Here at Red Whale, we thought this was a good time to discuss grief too. Today, we're going to look at grief responses, supporting people with grief, including the needs of children and clinicians, and prolonged grief disorder. So, what is grief?
Unfortunately, we all know that loss is an inevitable part of life. We have all lost something significant in life, and many of us will have lost someone. Grief is a natural response to this. It's not an illness or a mental health disorder, but a normal psychological process. Being mindful of this when we experience grief ourselves and reminding those who we are supporting of this can be extremely beneficial. But even knowing this, we must acknowledge that coping with a significant loss can be among the most challenging experiences that a person faces.
Grief will often follow a significant bereavement, such as the death of a family member, close friend, or colleague. It can also arise after a non-death loss, the real or perceived loss of something meaningful. These losses can be sudden or gradual, public or private, temporary or permanent, but all involve recognising that something is no longer as it once was. Examples include the loss of a job, breakdown of a relationship, a significant change or loss of physical ability, loss of cultural identity when migrating to a new country, or realising that a hoped-for future is no longer possible. And that comes from the Adultspan Journal in 2020. And it comes as no surprise that clinicians are a vulnerable group when it comes to grief. Experiences that you've had yourself may resonate with some of the points mentioned in the article by Health Service Insights that was published in 2025. Fee, can you tell us more about that?
Yeah, absolutely. Health professionals are vulnerable to grief through the nature of our work and maybe due to some traits within our personalities. Many clinicians encounter repeated experiences of death and dying in their work, which can carry significant emotional, psychological and physical effects. These reactions are often hidden or managed privately because patient care and workplace demands tend to take priority. Personal bereavements and other experiences of loss can also affect how clinicians respond to patients presenting with grief. They may strengthen empathy, rapport and coping skills, but it can also heighten vulnerability, and that comes from the Health Service Insights in 2025. Nick, I know I've certainly found this myself when a patient is experiencing something that you've experienced right in front of your eyes. Well, gosh, for me, it was almost like I could feel their pain. I know that sounds a little bit dramatic, but I think sometimes, things just, the combination can just get you, can't it? And for me, it was really difficult to navigate. But of course, there never feels like there's enough time to even think about how we approach this, be that within ourselves, if we even recognise it in the first place, because sometimes it can be a very subconscious thing, can't it? Or even when we're trying to support colleagues.
Yeah, I know what you mean. And we'll discuss ways to support clinicians experiencing grief a little bit later on. But if we look first at early grief responses, so if we think about grief in the early phase of loss, grief is unique to each person, and an individual may experience bereavements very differently at different points in their life. Culture, ethnicity, and spiritual beliefs may also influence how grief is expressed and how people cope. In the early period after a loss, grief often feels overwhelming and it can disrupt daily life. People may be surprised by the intensity of their emotions or their difficulty focusing on everyday tasks, or by experiencing brief sensory perceptions of the deceased. Common early grief responses can include a wide variety of symptoms. The following list comes from the BMJ article from 2017 and a Lancet article in 2007. We've divided them into 4 groups: emotions, thoughts and cognitions, behaviours, and physical reactions. So if we look at emotions first, then we'd have things like sadness, despair, depression, all those things that you expect. Also things like anxiety, fear, and dread. There might be guilt and self-blame, anger and irritability. There could be loss of enjoyment and pleasure, yearning, longing, and loneliness, or even shock and numbness. If we look at thoughts and cognitions now, there could be recurrent intrusive thoughts of the deceased. There could be disbelief or difficulty accepting the reality of the loss. There could be the sense of presence of the deceased. There might be helplessness, hopelessness, or self-reproach. There might be a loss of sense of self or purpose. There could be thoughts of suicide. There might be difficulties with focus, concentration, and forgetfulness, and also feeling disconnected from others and the wider world.
And then we have behaviours, so we might see things such as agitation, tension, restlessness and searching, weeping and crying, overactivity, or the opposite, social withdrawal. And physical reactions, loss of appetite, sleep disturbances, fatigue, loss of energy, or even somatic symptoms such as palpitations, butterflies in the stomach, dizziness or fogginess. For most people, grief gradually lessens over time as they adapt to life after loss. Many find new ways of living with the absence, drawing on personal coping strategies, social support, and cultural or spiritual resources. However, a minority continue to experience enduring distress that can interfere with daily life. Several models have been developed to describe the process of grief and how adaptation unfolds. So let's take a look at those now, as they can help us to support others and ourselves.
So when we think about the grief process, in inverted commas, we know that grief doesn't follow a straight path, and there is no single way that people adapt after loss. Various models have been developed to help make sense of these experiences. They're not rigid formulas, but flexible frameworks that describe the diverse emotional, cognitive, and behavioural responses that may arise.
And I think most of us will have heard of the 5 stages model of grief, which was described by Elizabeth Kubler-Ross in 1969. Kubler-Ross describes grief as proceeding along a series of predictable stages. Now, this can be useful for us in understanding some of the different reactions that people may have to a significant loss. Kubler-Ross acknowledged that people may not move through these stages in a fixed order, and that some individuals may stay longer in one stage or move back and forth between them. However, the model has been criticised for presenting grief as a series of predictable steps. Because in practice, grief is highly individual. People may experience a range of grief emotions that may appear in any order, recur over time, or fall outside the 5 stages altogether. And as a Lancet article reminded us, published in 2007, individual and cultural differences can both influence how these processes unfold.
And if we look at the dual process model now, so this is from Strobe and Shute in 1999, and it suggests that grieving involves moving back and forth between 2 modes of coping. Loss-orientated coping, directly confronting and experiencing the pain of the loss, and restoration-oriented coping, attending to the practical and social changes that follow bereavement. This oscillation between loss and restoration is considered a normal, adaptive part of the grieving process, allowing people to face their loss in manageable steps whilst continuing their daily life.
And then we have the task-based model. This is known as the tier model, which describes 4 tasks of healthy grief, and that comes from Worden in 2008. There's no recommendation or specific order in which to achieve these. Instead, it highlights the active steps many people take as they gradually adapt to bereavement. So T is to accept the reality of the loss. Moving from shock or disbelief towards the acceptance is the first step in adapting and moving forward. Rituals such as funerals and memorial services can help with this. E is for experience and process the pain of loss. This involves facilitating the safe expression of all the natural grief reactions. A is adjust to a world without the deceased. We slowly adapt to the change in our life and start to see the possibility of purpose, meaning and happiness. And R is reinvest in a new reality and a new life, finding ways to move forward through life while finding meaningful ways to keep a connection to the person who has died.
So what do you think about these models? Maybe you've got some insights into how they help, where they might be lacking. Maybe some of them are new to you. Fee, what do you think?
Well, I think they are just that, aren't they? They are models that heighten our awareness and they help us to make sense of things and be alert to things. But they are just that. They are models. And I think things like this are best used when you understand a few different versions and then use parts of them that help you in a particular case, which of course may change between individuals. I have to say, on a personal level, when my dear dad died a couple of years ago, I felt like I'd actually changed as a person, like entirely. It was almost like my life had gone from like travelling in one direction, say south-north direction, and now it was east-west, like I'd turned 90 degrees and life wouldn't ever be the same. I don't know if that makes sense, but I wanted to share that because it was something that I wasn't expecting, and it really challenged my previous beliefs about grief being a process to work through. And we have used that word process, haven't we, even today when talking about it. And the other thing I wanted to share is around anticipatory grief, because my father had dementia, and to some degree we had been grieving various losses for many years. So when he died, it was a really strange experience in some ways. It was overwhelming loss, but also some comfort for him and for us. Then there was some guilt about feeling too sad, even though he'd had a really good life, and some guilt around not being upset enough and finding comfort in his not suffering anymore. And I think that as we as a society experience more and more long-term illness, and especially dementia, we are going to have to be, as clinicians and just humans, better at supporting each other through this anticipatory grief stuff.
Absolutely. And thanks for sharing that, Fee. And I think there's been some campaigns recently regarding dementia and what you were saying about how, you lose somebody with dementia several times,
multiple times. Yeah, exactly. Yeah. They sometimes refer to it as the small deaths and then the big death.
Yeah.
And I couldn't agree with that more, because, and sometimes you don't even know. You don't, it's only when you look back that you realise those iterative losses.
And I'm sure, as we've been saying, that we all have experiences, and it's so helpful to reflect on those here. And we're going to be talking later on how to support clinicians who are dealing with grief in particular, because that's something that we all need to be able to do. So let's move on now to thinking about how we support people experiencing grief. For many bereaved people, support from family, friends and community networks is enough to help them to adjust to the painful reality of loss without the need for formal intervention. Others may also benefit from bereavement support from a range of statutory, community, charitable and voluntary organisations, including the primary care team, bereavement counsellors, social care workers and hospice and palliative care services.
So what is our role in primary care? Although bereavement care is recognised as a part of primary care, many clinicians report feeling unsure or insufficiently prepared to support people experiencing grief, even after training. There may be concerns about managing time and workload pressures, plus health professionals supporting distressed, grieving patients can suffer a personal emotional toll. We may also fear medicalising grief or maybe intruding into a private life event, particularly if we don't know the individual or their family very well.
There may also be uncertainty and a lack of awareness among clinicians about how and when to recognise complicated grief or prolonged grief disorder, or what to do in response. Nevertheless, primary care clinicians are highly skilled communicators who are well placed to support patients with their experiences of grief based on a strong, trusting relationship with the patient. Following a bereavement, many patients value receiving acknowledgement and contact from their GP and the opportunity to speak about their grief in primary care. However, practical and administrative challenges make this difficult, particularly if a deceased person was registered at a different practice from the bereaved patient. And this comes from the BMJ in 2017 and 2021.
So bearing in mind what we've discussed so far, let's look now at the Royal College of General Practitioners framework entitled A Compassionate Bereavement Response, which provides a simple structure for offering brief, effective support in primary care for those who are grieving. It has 4 steps and suggestions on what we might say. So, we should acknowledge the loss.
Fiona, I'm so sorry to hear.
We should ask about current support.
How are you getting on? Who else close to you has been affected by the loss? Who do you have around you for support?
We should advise on support options.
Support can make a real difference for many people. What other support do you think might help you right now? Some find it through friends, family or their community, and there are also organisations that can help. Is there anybody that you feel able to reach out to? You can come back and see me at any time if you need some more support.
And then we should act on the person's response and record the bereavement. We should show kindness and give space for their response, offer information about local and national support organisations, and seek guidance from a senior colleague if you have concerns.
Other micro skills to have in our primary care toolkit are offering bereaved patients the opportunity to talk about their grief, including the person who's died, or the thing that they've lost if it's a non-death grief response, and how they've been coping. When relevant, we can openly discuss patient questions or concerns about medical care received by the person who died, or about the last days of life. Encouraging social connection and support, a healthy lifestyle, and providing advice on sleep hygiene can be helpful too. Over time, the patient will benefit from reducing avoidance of reminders of the loss and slowly beginning to create a new life. We can use brief behavioural activation to encourage engagement with valued activities such as family life, work, hobbies, physical activity, and self-care activities.
Sometimes grief exists beyond the expected cultural and social norms of grieving, and this is now recognised as prolonged grief disorder and is listed as a mental health condition in both ICD-11 and DSM-5. Both define it as a persistent and disabling grief response that extends beyond expected cultural and social norms of grieving. They differ slightly in how long symptoms must persist before a diagnosis can be made, but both definitions share substantial overlap in emphasising separation distress, emotional pain, and functional impairment as core features. Around 3 to 10% of people bereaved by natural causes developed prolonged grief disorder, with higher rates after sudden or traumatic losses, and that comes from NEGM in 2024. However, prevalence remains uncertain due to inconsistent diagnostic criteria and wide variation by circumstances of death.
Risk factors for prolonged grief disorder include pre-existing depression or significant symptoms of grief before the loss, previous traumatic stress or earlier traumatic loss, violent or sudden death such as suicide, accident, unexplained medical illnesses, or natural disaster or war, use of alcohol or other substances, family conflict, social isolation or lack of support, or experiences of poor care or lack of comfort or insensitive communication from the healthcare team.
Nick, can you tell us how we would recognise prolonged grief disorder?
Yes, of course. So the key features of prolonged grief disorder would be persistent and intense longing for or preoccupation with the deceased, intense emotional distress such as sadness, guilt, anger, blame, bitterness, or difficulty accepting the death, avoidance of reminders of the loss, or alternatively excessive preoccupation with the circumstances of the death, marked difficulty engaging in daily life without the deceased, including social withdrawal, mistrust of others, or inability to find meaning or purpose, loss of identity or sense of self, or a feeling that life is meaningless or empty. The disturbance causes significant distress or functional impairment, or requires considerable effort to maintain daily functioning. And diagnosis can be made from 6 months after a loss in ICD-11 and from 12 months in adults or 6 months in children in DSM-5-TR.
So, if we suspect this, then some useful questions to ask to assess for prolonged grief disorder would be, can you tell me about the person who died and your relationship with them? How has life been for you since the loss? In what ways is your grief affecting your daily life? Are there things you avoid or feel preoccupied with because of the loss? What helps you to cope, and who do you feel able to turn to for support? Do you feel able to imagine a future, or does that feel very difficult right now? And of course, you don't have to remember these, but now you have an awareness, know that you can look them up in Redwell Knowledge if this springs to mind.
And a question that often comes up is, are we just medicalising grief? And you may even be thinking this as you listen. Here's what we know about that. Grief is not an illness. It's a natural response that occurs as a bereaved person adapts to their loss. There is a concern that labelling prolonged grief disorder as a mental health condition could stigmatise this group or undermine individual coping skills or seeking support from family and friends. However, giving a diagnosis of prolonged grief disorder may be helpful for some individuals. It can be a comfort and a relief to the bereaved person to help them understand their experiences and shift from self-blame about being unable to cope into confidence that treatment might help. And that's from the BMJ in 2017.
So, Nick, can prolonged grief disorder be prevented?
One of the issues here is that it's an evidence-light area. As we just said now, prevalence remains uncertain, and the following comes from the Lancet in 2025, the BMJ in 2017, and Psychiatry Research in 2024. Evidence for prevention remains limited. Universal approaches for people without risk factors may have little benefit, whereas targeted support for higher risk groups shows more promise with small to modest effects. Family-focused therapy in advanced cancer care begun during palliative care and continuing into bereavement has been shown to reduce risk compared with standard care. Cognitive behavioural interventions may also help, as can family-based support in settings such as cancer or intensive care. Some coping patterns after bereavement may increase the risk of prolonged grief disorder. Persistent avoidance of reminders, repetitive ruminations about the loss or its unfairness, and ongoing attempts to maintain closeness with the deceased may all predict later difficulties if continued beyond the early months. While maintaining a bond can be a healthy part of grieving, it becomes problematic when it prevents adaptation and engagement with ongoing life. So what does this all mean? Well, in primary care, we can support healthy grieving by listening, encouraging social interaction, and promoting gentle re-engagement with daily life, whilst helping patients recognise when avoidance or rumination may increase the risk of grief becoming persistent and disabling. We can also signpost to the many support services available, and there are some links for those in the article.
So what about treating prolonged grief disorder? A tiered approach to bereavement care can be useful here. While most people adapt with support from family, friends or community services, a smaller group may need specialist psychological intervention. Access to such care, however, remains uneven and limited in many areas. Psychological therapy is the first-line approach. The goal is to support acceptance of the loss and re-engagement into a meaningful life without the deceased. CBT has the strongest evidence base, reducing distress and aiding adaptation by addressing memories, beliefs and unhelpful coping behaviours. The key components of the therapy include behaviour activation, so restoring valued roles and activities while reducing avoidance and rumination, cognitive techniques, challenging negative beliefs about the self, the future, or the safety and predictability of the world, and this is particularly important after a violent loss. Exposure, reducing avoidance by revisiting memories, situations, or objects linked to the loss. Specialised CBT and family-based programmes tailored for children and young people have also shown effectiveness across cultural contexts. Approaches such as eye movement, desensitisation and reprocessing, EMDR, compassion-focused therapy and mindfulness have yet to show consistent benefit.
And you might be wondering about medication here. Well, medication has a very limited role. Antidepressants may be helpful for coexisting depression, but as we've alluded to earlier, don't treat prolonged grief disorder itself. Benzodiazepines, as you'd expect, are not recommended because of the risks of dependence and their potential to interfere with the learning and memory processes needed for adaptation.
Yes, I thought that last point on adaptation was interesting and actually would be a good risk to raise with patients or family members if they were asking for a prescription of benzodiazepines.
Yeah.
Nick, what about children and prolonged grief disorder?
Good question, Fee. Well, rates of prolonged grief disorder are around 5 to 10% in children. Features in children are often similar to those in adults, but are expressed in an age-appropriate manner. For example, a young child might persist in being obsessed with death-related play. In children who've lost a parent, the family bereavement program that aims to build resilience in the child has been shown to reduce immediate and long-term emotional problems, but access to this intervention is currently very limited. And CBT has been shown to be beneficial as well.
So moving on now to referral, when should we refer? Well, we should consider referral to specialist mental health services when grief symptoms persist beyond 6 to 12 months and significantly impair functioning, and that's in both adults and children. Earlier referral can be considered if there is coexisting depression, post-traumatic stress, major role impairment, substance misuse, or suicidal ideation, and that comes from the BMJ in 2017.
So we've mentioned the differences between grief and other mental health conditions, but what happens when they overlap or trigger each other? Prolonged grief disorder is linked to poor physical health, suicidality, reduced quality of life, and functional impairment. It's distinct, but has a high comorbidity rate with depression and PTSD. Bereavement can also trigger mental health problems such as depression, which may be difficult to distinguish from early grief, as well as anxiety disorders, alcohol or substance misuse, and episodes of mania. Fee, how do you think of grief and depression?
So I was taught a few years ago, and this was by a psychologist actually, to think of how grief and depression would look like on a graph. So if, for example, you had mood on the y-axis, starting at low mood and going up to normal mood, and on the x-axis you had time. Now, depression would look a bit, like a negative graph, like going downward over time, or maybe just staying low and rarely going back up, or maybe having the odd return to normal mood. Whereas grief would look like highs and lows repeated, like a tennis ball kind of bouncing along. So that's sometimes getting back up to normal, but with lots of low moments as well. And I find that helpful to share with patients, because that idea of still experiencing moments of positive emotion, but also, those lows that can happen that may just come out of nowhere. And often that will make sense because these people may well still be seeking the company of others. And that's in comparison to those with depression who will probably experience social withdrawal.
Exactly. Alongside that, they might also experience that intense yearning or longing for the deceased or the loss that's experienced, with symptoms often being most severe when the person is thinking about their loss. But what would we do if we thought that grief and depression were occurring? Maybe the grief has triggered pre-existing depression.
Yeah, good question. According to the DSM-5, which was published in 2022, major depression can be diagnosed from 2 weeks after a bereavement if full criteria are met. We as clinicians should then consider whether watchful waiting is appropriate or whether active treatment is needed in the presence of suicidal thoughts, major role impairment, or marked clinical deterioration.
If we think about grief and trauma now, the other mental health condition we may see or even experience is post-traumatic stress disorder. PTSD can arise after bereavement, particularly when the death is sudden, violent, or perceived as preventable. Both prolonged grief disorder and PTSD may follow loss, but they are distinct conditions.
Nick, can you just tell us how they differ, please?
Yes, so prolonged grief disorder involves persistent yearning and preoccupation with the deceased, usually linked to separation distress and often accompanied by bittersweet memories. PTSD symptoms are driven by traumatic distress with intrusive memories, nightmares, flashbacks, hypervigilance and avoidance, and often centred on the circumstances of the death. The two may overlap, especially after sudden or violent loss, but require different treatment approaches. Unlike prolonged grief disorder, when referral is usually indicated only once disabling symptoms continue beyond 6 to 12 months, PTSD can be diagnosed after just 1 month. NICE NG 116 from 2018 recommends referral for psychological assessment and treatment of PTSD if symptoms are severe, persist beyond 4 weeks, or cause significant functional impairment.
So in primary care, it's therefore really important for us to actively consider trauma following a bereavement and to assess for PTSD symptoms, because timely recognition and early referral may be crucial in preventing further deterioration. So let's move on now to supporting clinicians through grief. Grief is a significant and important experience that can have a major impact on clinician well-being. And as we said right at the top, even aside from what we may experience in our personal lives, working in healthcare makes us vulnerable to grief. And of course, by now, we know that this can take many forms, not just witnessing or experiencing loss through death. So what can we do? Well, recognising and acknowledging the emotional effects early can help to reduce the risk of distress building up over time within ourselves and noticing it in others. Some simple practical steps from Health Services Insights from 2025 include seeking support from colleagues. Our team is often the most meaningful source of support, especially after a loss at work. Checking in regularly with each other and giving space to talk after a difficult death, even briefly, can help to reduce feelings of loneliness, guilt, or self-doubt. If it seems likely that an event will affect someone more deeply, plan a follow-up conversation later in the day or week.
Create small pauses after challenging cases. Busy workloads or rapid transitions between patients can get in the way of natural processing of grief. Even 1 or 2 minutes to pause and reflect can help clinicians start to make sense of what happened. This might involve a quiet moment outside, taking a few slow breaths whilst making a drink, or a few simple grounding techniques to regain emotional stability before moving on to the next patient. Our article, Notice the Now, highlights a simple tool for coping with distressing thoughts or emotions.
Connect with family and friends. Time with friends, family and loved ones outside work can offer warmth, perspective and a sense of normality, as well as reassurance and a sense of connection. It is often best to avoid detailed discussion of specific cases outside the workplace, however, because colleagues who share our clinical context are better placed to provide detailed case-specific support. However, shared activities, light conversation, or simply spending time with people who care about us can ease the emotional impact of a difficult day.
Seek formal support when needed. This might include a debrief with a colleague or supervisor, a planned discussion at the end of the day, or accessing local psychological or mental health support if grief becomes persistent or starts to interfere with work. And before we finish with our take-home messages, please remember that support is out there if you or a colleague are dealing with grief. Do have a look at the links at the end of the article. There are some really brilliant resources in there, from e-learning with the Good Grief Festival to the toolkits that we've mentioned today. Do take a look and share your learning with your colleagues. So here are our take-home messages for grief. Grief is highly individual and people respond to loss in different ways. Intense emotions are common and can affect daily life, but for most people, the distress is temporary and does not develop into a mental health condition.
Prolonged grief disorder affects around 5 to 10% of bereaved people, with a higher risk after death of a partner or a child, violent losses, or in people with pre-existing mental health problems.
Suspect prolonged grief disorder if distress remains persistent beyond 12 months, is impairing daily functioning and is outside cultural norms.
Traumatic grief includes features of PTSD, can be diagnosed from 1 month after the loss and is treated with trauma-focused therapies.
Clinicians are vulnerable to grief, and there are simple practical steps that we can take to support ourselves and each other.
And finally, there are many sources of bereavement support, and signposting is an important role for us in primary care.
Hello, Red Whale Pod. We wanted to share that we're currently looking for 4 new clinicians to join the Red Whale team to help us create and curate our educational content.
Not sure if that's you? Well, do you still love general practice or same-day emergency care, even with all its challenges? Maybe you have a passion for producing medical education that makes your colleagues' lives easier.
Perhaps you can be found quickly sketching diagrams or flowcharts to make complex things simple for colleagues or patients, or maybe you secretly know your p-value from your confidence interval.
If this sounds like you or a colleague, you can find more information in the Join Us section of our website. We'll put the link in the show notes. The closing date is Friday the 27th of February.
And here's Fee with the Red Whale calendar.
So it's an exciting time as February is our new filming month. Lots of new articles and video bites will be coming over the next few months, so do keep an eye out. With that in mind, you can book onto the new GP Update courses, face-to-face Thursday the 26th of March in Manchester with Hussein and Susan, then again on Thursday the 23rd of April and Friday the 24th of April in London with them both too. And if you prefer to join us for a live digital course, where it's probably more acceptable to wear your pyjamas, then join Kate and Catherine on the 27th of March, live from the studio. Mike's in the studio on Friday the 6th of March for our MSK and chronic pain course, which is packed with micro skills to strengthen our consultations. And if cancer is on your PDP list, then join our specialist cancer team on the 17th of April. And if you're attending any of our courses, then please do say hi to the Red Whale clinicians and let us know if you'd like a shout out on the podcast. OK, so let's talk about meningitis and meningococcal disease. Right, quick quiz, Nick. Ready?
OK, I think so.
It's easy, right? Okay. Meningitis, is that something you want to miss?
No.
That's correct.
OK, that was easy, thank you.
Well, that might have been easy, but how often have you seen it?
Not much, actually.
Exactly. So this is one of those cases where our knowledge needs to outweigh our experience, as we said.
Yeah. So just like alpha-gal last month.
Just like alpha-gal. Okay, next question. Are meningitis and meningococcal disease the same?
Okay, I'm not sure I've actually even thought about that, to be honest.
No. So all joking aside, we're talking about this today for 2 reasons. 1, because NICE updated their guidance on meningitis and meningococcal disease in 2024, so we need to know what those changes are. Mm-hmm. And 2, because it's a serious condition that we don't want to miss. In the guidance, NICE clearly distinguishes between bacterial meningitis and meningococcal disease, although of course the 2 do overlap. The guidance for bacterial meningitis includes meningococcal meningitis and meningitis caused by other bacteria. The guidance for meningococcal disease covers meningococcal sepsis, both with and without meningitis.
OK, so why does this matter to us actually on the ground?
Well, it matters because it affects what we do when we suspect either bacterial meningitis or meningococcal disease. So we'll discuss that. So before we get on to looking at NICE's 2024 update, let's recap a little on some pathophysiology. Bacterial meningitis is still an important cause of death in the UK, with an overall case fatality rate of 10%. Since the introduction of Haemophilus influenza B, Group B and C meningococcus and pneumococcal vaccinations, bacterial meningitis and meningococcal disease rates have fallen dramatically, which is fantastic. The most common pathogens for bacterial meningitis are Neisseria meningitidis for those aged 3 months to 14 years and Streptococcus pneumoniae bacteria for those 15 years and older. Serogroup B meningococcus is the cause of most cases of invasive meningococcal disease, and that all comes from the UK HSA in 2024. Now, the reason we don't see bacterial meningitis and meningococcal disease often is due to the vaccination programme. Prior to this, up to 20% of children presenting with fever and a non-blanching rash would have invasive meningococcal disease. Now, this figure is closer to 1%. And hib meningitis is also now rare. Do remember that bacterial meningitis and meningococcal disease are notifiable diseases in the UK. So, Nick, why don't you tell us what's new in the NICE 2024 guideline?
Yes, so in 2024, NICE completely rewrote its guideline on bacterial meningitis and meningococcal disease. One of the themes of this guidance is suspicion. NICE bases its guidance on how strongly we suspect bacterial meningitis or meningococcal disease. It divides the guidance into those with strongly suspected meningococcal disease or strongly suspected bacterial meningitis, and then those with simply suspected meningococcal disease or bacterial meningitis.
Okay, but what constitutes a suspicion? It feels a little bit traitor-esque, actually, doesn't it?
Well, yes. Get your cloaks ready. But we need a bit more than a feeling, don't we? As we also do in the trailers. We need some evidence or something, don't we? Now, NICE gives us clusters of features to look for. So first, let's consider strongly suspected meningococcal disease. NICE states that the red flag symptoms for strongly suspected meningococcal disease are hemorrhagic, non-blanching rash with lesions of more than 2 millimeters, or non-blanching petechial or purpuric rash, or symptoms and signs of bacterial meningitis with a non-blanching rash. Any of these red flag symptoms warrants an immediate 999 ambulance and pre-hospital antibiotics unless it will delay transfer.
Right, so to be clear, any of those features is present, then we're calling 999 for an immediate ambulance and giving pre-hospital antibiotics, unless, of course, that would delay transfer. And those antibiotics would be IV or IM ceftriaxone or benzyl penicillin.
Yeah, that's it.
So the next group is strongly suspected bacterial meningitis. So in its guidance, NICE is very clear about the red flag combination for bacterial meningitis. And this is a cumulative cluster, so ands rather than ors that we had above. So this is fever and headache and neck stiffness and altered consciousness or cognition.
And they mentioned this one quite a lot in the guidance, didn't they?
Yeah, this combination is mentioned 17 times. So clearly something NICE really wants us to remember.
And the reason this is all 4 features, that is fever and headache and neck stiffness and altered consciousness or cognition, is because a person with all the symptoms in the red flag combination is highly likely to have bacterial meningitis, and this warrants an immediate 999 ambulance.
That's right. And in this situation, pre-hospital antibiotics are only given when a significant clinical delay in transfer is expected. Annoyingly, NICE doesn't say what constitutes a clinically significant delay, but this is a deliberate omission due to lack of evidence.
Okay, so that's strongly suspected meningococcal disease and strongly suspected bacterial meningitis. What about suspected bacterial meningitis and suspected meningococcal disease? Are we sending them in too? And what about pre-hospital antibiotics? And how do we suspect bacterial meningitis and meningococcal disease?
Now, these are all great questions, Nick, and something that you listening might be asking yourself too. So all of these groups need to transfer to hospital in an immediate 999 ambulance. The key difference is that those with suspected disease are not considered for immediate pre-hospital antibiotics. Okay, does that make sense?
So far.
Well, I'm sorry, but NICE take this opportunity to throw the primary care spanner in the works here.
Oh, no, go on, tell me then.
So NICE cautions us that bacterial meningitis can still be strongly suspected, even in those without those red flag symptoms, particularly in young babies and older adults.
Okay, so what do we do with that?
Well, here at Redwell, we think this means that if you are unsure whether someone has suspected or strongly suspected bacterial meningitis, treat them as strongly suspected bacterial meningitis. The priority in both situations is immediate 999 ambulance transfer to hospital. Remember that our clinical judgment comes into play. The more signs and symptoms someone has, the more likely it is that they have bacterial meningitis. So let's now think about risk factors. Just take 15 seconds now and think of any risk factors that would alert you to someone having suspected bacterial meningitis or meningococcal disease. Okay, so how did you get on? Nick, what did you get?
Okay, so I was trying to recall what's in the article and I broke it down into groups.
Well, that's good. I thought you were going to say you broke down.
Well, Goes without saying. So the 5 groups that I come up with. So number 1, I spoke about how vital immunisations have been. So the first group would be missed immunisations. So that would be meningococcal, Haemophilus influenza type B or Hib, and pneumococcal as well. And then group 2 would be about those with impaired immunity. So those without a spleen or with reduced function. And there was another one that I can't remember.
Yeah, no, you're right. So that's complement deficiency or complement inhibition.
That's the one. Okay. So then the third one is those with a history of meningitis. And that's a personal history of bacterial meningitis or meningococcal disease, or a family history of meningococcal disease.
Great.
And then the fourth group was other risks. So somebody who's a student or in higher education or further education, and that's particularly if they live in large or shared accommodation. And if a patient has had contact with somebody with Hib or meningococcal disease, or in an area with an outbreak of meningococcal disease.
Perfect. Well done. And can you remember the 5th group?
I remember that it was something specific to bacterial meningitis, but I'm gone. I don't know.
Yeah, no, that's perfect. Yeah, so with bacterial meningitis, it's those who have cochlear implants or a cerebrospinal fluid, a CSF leak. Cool. Okay, great.
Okay. Thank you. So now let's recap the symptoms and signs of bacterial meningitis and meningococcal disease. Now, NICE lists these in the 2024 guidance. And as always, some of these may be known to us and some less so. They divide them into what's seen in children, young people and adults, and what's seen in babies, and then some features that are seen specifically in meningococcal disease. So let's take a look. And if you've got the article to look at, then you might want to follow along, and you'll find it in subsection 1.7. So for children, adults and young people, altered consciousness or cognition, irritability, lethargy, unusual behaviour, which may be agitated, aggressive or subdued. There may be neurological features, so headaches, neck stiffness, focal neurological deficit, photophobia, seizures. There could be fever, sepsis or shock. They might have an ill appearance about them. They might be vomiting. There could be limb, back, abdominal or other body pain.
Abdominal pain?
Yeah, that's an interesting one, isn't it? I hadn't thought of that. No. And also pale mottled skin and cyanosis.
And NICE specifically mentioned that in babies, we may see other things like reduced feeding, a weak, high-pitched or continuous cry, bulging fontanelle, and tachypnea or apnea may be seen as well.
As we said, NICE also mentioned features that may be seen specifically in meningococcal disease. In adults, children and young people, these are non-blanching petechial or purpuric rash, cold hands and feet, raised heart rate, or a heart rate less than 60 beats per minute if they're under 12 years old, low blood pressure or cap refill more than 3 seconds, reduced urine outputs, leg pain.
Leg pain?
Yeah, that's right. Not something I'd associate with this at all, but more on that in a second. Also a temperature less than 36 Celsius, diarrhea, and the very important parent or carer concern, which we should always listen to.
That's right. And in babies, we may see grunting or a raised respiratory rate, temperature 39 degrees C or higher in 3 to 6 month old infants, or 38 degrees C or higher in those under 3 months of age. And of course, parent or carer concern there too. So let's unpick those surprising symptoms. The guidance incorporates some non-specific symptoms and signs such as leg pain and cold hands and feet. But what's the evidence? So this is based on a qualitative study of 450 children admitted to hospital with meningococcal disease, and it was included in the previous guidance too. A retrospective analysis collated the symptoms and signs that parents noted prior to admission. This was published in The Lancet in 2006. Many children with meningococcal disease had only non-specific symptoms and signs in the first 4 to 6 hours, so early in the disease, but most were close to death within 24 hours, highlighting the rapid progression of the disease and the difficulty diagnosing it at an early stage.
Goodness me, that's sobering, isn't it?
Exactly. And the classic symptoms and signs, the non-blanching petechial, purpuric rash, meningism and impaired consciousness, presented late with a median onset of 13 to 22 hours.
So we need to be acutely aware of these non-specific symptoms because we might be consulting early in the presentation.
Exactly.
Is there anything else that can help us here, Fee?
Yeah, there were some early symptoms and signs. So at a median time of 8 hours, 72% had developed early symptoms and signs of sepsis. So the ones that we mentioned that we were surprised at: leg pains, cold hands and feet, and abnormal skin colour. 76% of parents had noticed one of those early symptoms and signs prior to admission.
So that's pretty helpful. So we should remember to ask about leg pains, cold hands and feet, and abnormal skin colour, and educate parents about these in addition to the classic symptoms and signs.
Yeah, spot on. So that's all helpful, but I can't help feeling that this can still be a really difficult diagnosis to make or even suspect. It's one of those things that can seem really obvious with the retrospectoscope, but of course, we want to get it right from the outset. So let's think about some extra tips to help us.
I know exactly what you mean. Now, this is general practice at its toughest. When thinking could it be bacterial meningitis or meningococcal disease, we should consider the following. These are rapidly evolving conditions. A person can go from well to moribund within hours. Most deaths from meningococcal disease occur within the first 24 hours. Meningitis and sepsis can occur together, especially in those with a rash, but meningococcal disease can occur without a rash. Bacterial meningitis and meningococcal disease can be easily missed because young people and young adults may appear well at presentation, making it difficult to pick up. Antipyretics may mask fever, so ask if they've been used. Altered level of consciousness, cognition or behaviour in young people and young adults may be put down to alcohol or substance misuse, or in older adults, dementia or delirium. It may be hard to differentiate from other serious infections such as pneumonia, other forms of sepsis, non-bacterial meningitis or intracranial bleed. Symptoms such as headache and neck stiffness might not be reported in those with communication difficulties or cognitive impairment, and neck stiffness is less common and harder to identify in babies and older adults. The rash can be difficult to see in brown, black or tanned skin. In all skin types, check the whole body for a rash, including the nappy area and conjunctivae.
The bottom line is, if in doubt, we should arrange immediate transfer to hospital via 999 ambulance. So before we finish, let's think about safety netting. After your assessment, you may decide it's appropriate to send the person home. For example, a child with a fever and a blanching rash for several days who does not appear ill. If you send a person home after an assessment for possible bacterial meningitis or meningococcal disease, safety net carefully. NICE doesn't give any specific details here, but reminds us that a rash can change from blanching to non-blanching, in which case that person should return for assessment. We should ask them to return if they develop new symptoms or worsening of existing symptoms.
And this is where SMS or email messages can be really helpful too. So a possible take action point could be to mock up a message to send out, which includes watch points for meningitis, meningococcal disease and septicemia. There's some brilliant resources on meningitis now, and there's a link at the end of the article, and we'll put a link in the show notes as well.
And do have a look at the full article for more information, such as NICE's rationale behind pre-hospital antibiotics, whether we should admit every child with petechiae, long-term outcomes following bacterial meningitis and meningococcal disease, and whether having antibiotics in the preceding year increased subsequent risk of meningitis. But before we finish, let's just consider one of the questions we've often been asked on courses around this topic, and that is, can we advise a patient to be taken to the hospital by a relative or friend in their own transport if that will be quicker than an ambulance? Nick, what do you think?
Yeah, so this is a great question because whilst the intention is to help and get the patient the quickest care possible, leaning into the immediacy of the situation here, we can't ignore the safety aspect, and that needs to come first. Essentially, if we have somebody who meets these red flag criteria, determining that they need an immediate 999 ambulance, but then advise them that it's safe to go by other means, we're handing over responsibility to a layperson.
And that's not clinically safe nor defensible.
Exactly. And we need to hand over to an ambulance crew, an appropriate clinician-to-clinician professional transfer of care. Remember, meningitis and meningococcal disease can deteriorate rapidly and aggressively. So here are our take-home messages for bacterial meningitis and meningococcal disease. Consider the red flag combination for bacterial meningitis and the red flag symptoms for meningococcal disease.
If bacterial meningitis or meningococcal disease are suspected or strongly suspected, transfer urgently to hospital, usually via 999.
Give prehospital IV or IM ceftriaxone or benzoyl penicillin for strongly suspected meningococcal disease unless this will delay transfer, and for strongly suspected bacterial meningitis if you expect a clinically significant delay in transfer.
Remember, there may be non-specific symptoms and signs which may become more severe with time. Careful and specific safety netting and early re-evaluation are important.
Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale Pod members. How do you become a member of the pod, I hear you ask? Well, if you are listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, and it can only be used once. Red Whale Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few moments and we'd really appreciate it. And if you can spare a little more time, then please leave us a nice review too. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram and LinkedIn. If you want us to see something about the podcast, then please use the hashtag RedWhalePod.
The other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And if you want to tell us about a change to your practice that has come about by listening to us, then please email us at impact@red-whale.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.